We can start.
Good evening, ladies and gentlemen. Welcome to this session on thyroid neoplasms. Janani, our postgraduate, will be doing this session. Thyroid neoplasms are a pretty big topic, and I honestly don't think we can cover everything within an hour session, including our discussions and things like that. So what I've told Janani is to keep going at our normal pace, try and cover as much as possible, and almost certainly we will need another session to complete the whole topic. I know there will be a lot of repetition because I have myself been involved in so many sessions on thyroid, clinical examination, lumps, goiters, and benign and malignant disease. But here, Janani will be speaking in the context of, let us say, answering a main question on thyroid neoplasms. And so she'll be a little more theoretical, and as and when required, we will chip in with the clinically relevant aspects as well. Over to you, Janani.
Sir, thank you, sir. Good evening, everyone. Am I audible, sir?
Yes, you are.
Yes, sir. Good evening, everyone. So we are going to talk about thyroid neoplasms. The plan for the talk will be introduction, etiology, pathophysiology, presentation, workup, staging, treatment, follow-up, and take-home message. Thyroid neoplasms are the most common endocrine tumor, responsible for about six deaths per million persons annually. So it accounts roughly for about 0.5% of all cancers in men, 1.5% of all cancers in women. The 5% of all thyroid nodules are malignant. Single nodule, that is solitary nodule, is more likely to be malignant than multiple nodules. Classification of thyroid neoplasms, it can be benign or malignant. Benign can be follicular adenoma, Hürthle cell adenoma, or colloid adenoma. Colloid adenomas are most common. And malignant can be differentiated, undifferentiated, medullary carcinomas, malignant lymphomas, and secondaries from colon, kidney, and melanomas. The differentiated can be papillary, follicular Hürthle cell, and or papillofollicular carcinomas. And undifferentiated tumors can be anaplastic carcinomas. The annual incidence of thyroid neoplasm is 0.5 to 10 per 1 lakh persons. The highest incidence is seen in Northern America. Female to male ratio ranges from 3:1. The differentiated carcinomas peak in third and fourth decade of life. Medullary carcinomas peaks in fifth and sixth decade, and anaplastic carcinomas in 70 and 80 years of age. Thyroid cancers can arise from two types of cells. As we know, endodermally derived follicular cells like papillary, follicular, and anaplastic carcinomas, and calcitonin-producing C cells like medullary thyroid carcinomas. And thyroid lymphomas arise from intrathyroid lymphoid tissues. The sarcomas can arise from connective tissue of thyroid gland. The risk factors for thyroid neoplasm ranges from radiation, pre-existing multinodular goiter, Hashimoto's thyroiditis, and familial cancer syndromes. And these include Cowden syndrome, familial adenomatosis polyposis, and Werner's syndrome, Carney's complex type 1 syndrome, and McCune-Albright syndrome. The medullary carcinoma and the associated syndromes like MEN 2A and 2B syndromes, and familial MTC syndromes. These are the oncogenes and tumor suppressor genes that are involved. The most important are BRAF, RAS, and RET mutations. And the tumor suppressor genes, the most important are P53 and P10 mutations. So solitary thyroid...
Can I stop you there?
Yes, sir.
And ask you, what do you think is the importance of these? Just go back one slide.
Yes, sir.
The genetic studies.
Yes, sir.
Why do you want to know about this?
Yes, sir. Sir, the mutations of the proto-oncogenes, like the RAS and RET mutation, if it is involved, there are high chances of metastasis, distant metastasis. So nowadays, the gene studies can also be done to know the invasiveness or aggressiveness of the tumor, sir.
Right. Anything more important than that?
I'm not sure, sir.
Sir, can I come in, sir?
Yes.
Sir, for men 2A, 2B syndrome, sir, if we do genetic study within, like for men 2B, if there is familial history of other like hypoparathyroidism or pheochromocytomas, the genetic study done earlier, like for a men 2B, we have to do within first year only genetic study, and for men 2A and familial medullary thyroid carcinoma, we can do within 5 years. So if that is there, and the mutation is there, genetic mutation is there, then we may have to do a prophylactic thyroidectomy. That's why genetic
not just meant to. You're right, partially. It's not just meant to. Even in other familial carcinomas, which are rare, but if you do a genetic study, you can, when certain defined genetic mutations are described or detected, you can rest assured that the child will have a cancer within the first decade. All right, and so you need to do a prophylactic total thyroidectomy on these kids. Now, in my career, I've done it twice, based only on genetic studies. Okay, and so that is the important thing. One of them is, yes, to some extent, it tells you about the aggressiveness, but even more important is to screen the family for these genetic mutations and see if there is a role for prophylactic total thyroidectomy in the siblings of the index patient or the children of a patient who has had one of these mutations. Okay, some of these transmissions are autosomal dominant. Some of them are recessive. You need to know which one goes which way. Honestly, I cannot remember which one goes which way, but it's all documented. So if you feel that it is an autosomal dominant kind of transmission from the mother to the child will come up with a cancer. And so you need to do a prophylactic total thyroidectomy. These are very rare. As I said, in all my career, I've done it only twice, but that's something you have to bear in mind. The other, just go back one step. You talked about radiation as, in one more slide.
Yes, sir.
Radiation as a risk factor. Radiation is rather unusual nowadays, but what were the situations where radiation, there is a risk of radiation exposure in childhood?
Sir, like lymphomas, sir.
Okay.
Lymphomas.
Okay.
Bone marrow irradiation.
No, you're talking about radiation to the neck, right? When you're talking
Yes,
about,
sir.
yeah. So what is the commonest areas where children get exposed to radiation in today's age?
Head and neck, sir.
Yeah,
Head
I
and
know
neck.
head and neck only, but what is the clinical situation or what is the social or clinical situation where they get exposed to radiation? It's very rare, but I'm just asking, you need to know when would people get exposed to radiation?
Sure, sir.
What about Chernobyl disaster?
Yeah,
That's in fact the commonest. Okay.
Yes, sir. Yes, sir.
A nuclear reactor disaster is today the commonest. 3-4 decades ago, even before I started training, people used to give radiation for unusual diseases. Can you think of a few unusual diseases? Anybody?
Sir, in acne, they used to give radiation, sir.
Correct.
Previously.
Correct. Long ago, they used to give it for acne, which may sound very drastic, but they used to do that. And so they ended up, how long afterwards would they end up with a cancer of the thyroid? 2.5 to 3 decades afterwards.
20 years, yes.
Yes. 20 to 30 years afterwards, they would end up with a cancer. Shivaram, you want to add anything?
Nothing more. Very
Shrikant?
interesting. Yeah.
Yes, sir.
All right, please carry on.
Yes, sir. Thank you, sir.
Yeah.
So solitary thyroid nodule can be at the sir.
Hold, yeah. Go
Janani,
on.
1 minute.
Yes, sir.
Janani, why you think radiation will cause cancer?
Sir, mutation of the genes, sir, because of radiation.
Yes, correct. And in that, papillary thyroid will be most common.
Yes, sir. Papillary
Yeah.
thyroid. Yes, sir.
BRAF mutation. Yeah.
Yes, sir. So
What
solitary
is
thyroid.
what is the risk of developing papillary CA with BRAF mutation?
So sorry, sir. What is the
Risk of developing papillary CA with BRAF mutation.
percentage you're asking?
Yeah,
50%, sir.
yeah, very good.
Yes, sir. 50 to 60%.
Go on.
So can I continue, sir?
Please
Yes, sir.
continue. Yeah.
Yes, sir. So solitary thyroid nodule, the commonest site will be junction of isthmus with one of the lateral lobes. There are two types, toxic and non-toxic solitary nodule. So about the management of them, I'll discuss later. Papillary carcinoma can be occult, that is less than or equal to 1 centimeter of size, or intrathyroidal or extrathyroidal. And these are the other variants of papillary carcinoma to be kept in mind. Papillary thyroid carcinoma can be soft, firm to hard or cystic in consistency. It can be solitary or multinodular. Microscopically, orphan nuclei is the characteristic feature which we could see in FNAC sample and Samoma bodies. The spread of papillary thyroid carcinoma will be slow and progressive, and it is less aggressive. The most common spread is through lymphatics. The most commonly it spread to lungs, followed by bone, liver, and brain. And follicular thyroid carcinoma, invasive and
Just go
non-invasive.
back one slide, Janani. You say it is most common is through lymphatics.
Yes, sir.
Spread through lymphatics. So where would it
Yes,
go
sir.
to first? And then to call it most commonly to lungs, followed by bone, liver, and brain. That would be incorrect, isn't it?
Yes, sir.
Spread is first to the lymphatics. So
Lymphatics,
yeah,
yes,
it will
sir.
go to the lymph nodes first. And if you're
Yes, sir.
looking at distant metastasis,
Yes,
so
sir.
you should take away that word most commonly. The distant
Okay, sir.
metastasis are in that order. Okay?
Yes, sir. Distant
Most
metastasis most commonly to
commonly.
lungs, then yes, sir.
But
Okay, sir.
disease per se, the most common spread is to the regional lymph
Lymphatics.
nodes.
Yes, sir.
Correct. Go on.
Yes, sir. So follicular carcinoma can be invasive or non-invasive. Invasive type, the most common is blood spread, or non-invasive. The non-invasive spread, the spread, angio spread is not common. The typical features are capsular and angio invasion. It is follicular thyroid carcinomas are more aggressive tumor spreading through the blood into bones, lung, and liver. Occasional spread to lymph nodes is seen in around 10% of cases. Hurthle cell carcinomas, it is a variant of follicular carcinoma, also known as oxyphilic or axanthic or large cell carcinomas. 5% of them are differentiated. Hurthle cell carcinomas constitute 5% of differentiated thyroid carcinomas. More than 75% of Hurthle cell tumors are with oncocytic features. Oncocytic cells are large polygonal cells with abundant acidophilic cytoplasm. They differ from follicular cancer in all these features, like they are multifocal and bilateral in almost 30% of cases. 5% of Hurthle cell carcinomas do not take radioiodine, and most likely to metastasize to local nodes, that is around 25%. And Hurthle cell carcinomas are aggressive and potentially malignant if capsule or angio invasion is there. They are associated with higher mortality rate, that is around 20% in 10 years.
So the thing to remember is being follicular cancers, which are more commonly blood-borne than lymphatic spread, Hurthle cells do go to the lymph nodes as well. That's what you
Yes,
need
sir.
to understand. Okay,
Yes,
go on.
sir.
Yeah, they're more aggressive than the
They're more aggressive than
Yes, sir.
follicular.
ordinary
Age
follicular tumors.
Age group you didn't mention about this. Age
Sir,
group of Hurthle cell.
Yes, sir. 40 to 50 years, sir.
Typically, it will be above more than 60 years of age in elderly people,
Okay, sir.
and
Okay.
recurrence rate will also be high
Okay, sir.
in Hurthle cell carcinomas.
Yes, sir. So anaplastic carcinomas are undifferentiated, very aggressive carcinoma that is typically seen in mostly in elderly females. It is grossly firm and whitish and microscopically sheets of cells will be there, and heterogeneity is the marked feature, and one of the most aggressive thyroid malignancy that spread through lymphatics, and the secondary metastasis can be seen in lungs, brain, and bone.
It is not one of the, it is the most.
Yes, sir, the most.
In local spread is characteristic of anaplastic tumors.
Yes, sir.
Very infiltrative, and it can, as I said, local spread is very common. Yeah.
Yes, sir. So medullary thyroid carcinoma, there are sporadic and familial types, well circumscribed and unencapsulated. Microscopically, amyloid stroma will be there. And in amyloid, calcitonin is the finding in immunohistochemistry. The spread is mainly through lymph nodes. Medullary thyroid carcinoma can be associated with men type 2B with pheochromocytoma, that is also called Sippel syndrome, is the most aggressive type. These are the manifestations of various syndromes. So thyroid lymphomas, the most common thyroid lymphoma will be from non-Hodgkin's B-cell lymphoma, commonly arise from chronic lymphocytic thyroiditis. The chronic antigenic lymphocyte stimulation will lead to lymphocyte transformation into malignancy. So the association of Hashimoto's thyroiditis and thyroid cancers, the annual incidence of Hashimoto's thyroiditis is 0.3 to 1.5 cases per thousand people. Association, the range is between 9 to 10% with papillary thyroid carcinoma, and association of Hashimoto's thyroiditis and thyroid lymphoma, primary thyroid lymphoma is 0.3 to 0.5%. No association was found between any other like medullary thyroid carcinoma or follicular thyroid carcinoma. The chronic inflammation and elevated TSH, which leads to malignant transformation in thyroid gland. So Hashimoto's thyroiditis with papillary thyroid carcinoma has got good prognosis due to early detection and treatment. Sir, till this, any questions, sir?
Yeah. Any questions or comments?
Janani,
Sir?
in papillary thyroid carcinoma, you told favorable prognosis. No, any other variants, which do not show a favorable prognosis, means they will have poor prognosis. As in papillary thyroid, do you know any variants which have poor prognosis?
So tall cell variant has got poor prognosis, sir.
Yes, correct.
Yes, sir.
One more, that tall cell and
Insular
columnar.
variant, sir.
Yeah, columnar. Yeah.
Okay, sir. Yes, sir.
And if it is a papillofollicular neoplasm, which can be,
Okay,
can be combined, it is the prognosis is slightly worse than a pure papillary neoplasm.
Yes, sir. Yes, sir. So here about history and symptoms, as we discussed many times in our previous classes, I'm going to give in brief. The most common presentation will be painless, palpable, solitary thyroid nodule. Solitary nodules presenting before 30 years and after 30 years has got increased chance of malignancy, and nodules in males higher chances of malignancy. Papillary thyroid carcinoma is a slow-growing, painless mass with discrete neck lymph nodes. Around 40% will have discrete neck lymph nodes. Latent aberrant thyroid is cervical lymph node invaded by the metastatic thyroid cancer. The compression feature is usually uncommon in this papillary thyroid carcinoma. And follicular carcinoma can be solitary thyroid nodule with history of rapid increase in size and long-standing goiter. Tracheal compression can be seen. So stridor will be the symptom. The positive berry sign due to invasion of carotid sheath in advanced malignancy can be seen. Dyspnea, hemoptysis, and chest pain can be seen when lung secondaries are there. And pulsatile secondaries in the skull and long bones due to the invasion of the follicular carcinoma through bones. And cervical lymphadenopathy is usually uncommon. Signs and symptoms of thyrotoxicosis will be there.
Is that common?
Sir?
Signs of thyrotoxicosis, is it common in follicular carcinoma?
Not very common, sir.
It's
And
very
it is
uncommon.
very
It's
uncommon.
Yeah. Okay.
I mentioned it in last. Yes, sir.
Yeah,
If you have thyrotoxicosis, you don't investigate for malignancy only.
Yes, sir. Yes, sir.
It's extremely rare for the two to. It's happy. It can happen, but very rare. So please remember
sir.
that. Yeah.
Yes, sir. So physical examination findings that increase concern for malignancy includes nodules greater than 4 cm, firmness or hardness to palpation, fixation to the adjacent structure, and vocal fold immobility and cervical lymphadenopathy. These are the factors which we should suspect the risk of malignancy. So
What are the fixation to the adjacent structures?
So fixation to the trachea.
How do you find out?
Sir, we'll have to move the swelling across the.
Janani, you must
Sir?
really be thinking when you answer. You come out with, very quick answers and get into deep trouble. Is thyroid normally not fixed to the trachea? Is that not why it moves when the trachea moves?
So it is.
Yeah. So what is the point in saying it's fixed to the trachea to say it's malignant? Normally it is. Normal thyroid is fixed to the trachea.
It's adherent to the
sir.
trachea.
Okay. Yes, sir.
So what is this first structure that you talk about? When a neoplasm, just think about it. When a neoplasm leaves the thyroid gland, goes outside the capsule, what are the things that it is unlikely to invade around it?
Sir, I'm not sure, sir.
Why do you say you're not sure? You must work it out, right? What happens to the sternocleidomastoid muscle?
Yes, sir.
Not closing it.
Yes, sir.
So you would expect that some of it is fixed to the sternocleidomastoid muscle. Okay. And all of it you may not be able to elicit clinically, but these are the things that happen. You clearly mentioned about carotid sheath and invasion or narrowing of the carotid pulsation. All right.
Yes,
and if it goes posteriorly, it can go and narrow the esophagus. So there may be deglutition. Not all of this may be clinically demonstrable, but you must make an attempt to see if you can find that the carotid sign is very obvious, but eliciting the fixation to sternomastoid may be very difficult. But to say that fixation to trachea is something which is abnormal would be unacceptable. All right.
Can we tell it adherence, sir?
Adherence to how do you differentiate clinically?
Yes, sir.
So the invasiveness must be to the surrounding structures, which to my mind is sternomastoid.
That is one of the indications for CT scan.
Yeah.
So
cannot make out clinically.
Then somebody will ask you, how do you make out clinically? And you say, it's not always easy. So just say, get a scan and see how we can find out. And that is the way to answer. Yeah.
Yes, sir. So only dyspnea, dysphagia will be the symptoms.
Correct. And
dysphagia yakama barutte?
Sir, because it
only if there is compression only you get.
Compression.
Infiltration you won't get.
Sir. Okay, sir. Okay. Yes, sir. Yes, sir.
Go on.
By the time the lumen of it becomes so narrow, the patient would have died.
Okay, sir. Yes, sir. So
what is vocal cord immobility? How do you make out clinically?
Sir, first of all, dysphonia when patient is
change in voice and third.
Change in voice. Yes,
thanks,
sir.
Why are you
change in voice?
Simple things, ma. Change in voice.
Change in voice. Yes, sir.
Thank you. Go on.
So the differential
lymph node is involved first. Go back.
Sir?
Go back to the previous slide. Which lymph node is involved first?
Sir, level 4, sir. Level 4 and
Lakshman sir asked in the beginning only. No.
Answer here, Shrikant. Give
level
6, sir.
Level 6 is the first.
Level 6 is a pretracheal, paratracheal lymph node, sir.
Yeah. Followed by first 1, 2, 3, 4.
Yeah.
Okay,
2, 3, 4.
Okay. Yes,
level
sir.
6 followed by 2, 3, 4. Yeah. Go on.
Okay, sir. So the differential diagnosis will be multinodular goiter or thyroiditis, thyroid adenoma, or thyroid cyst. We'll work up the patient. Practically, we'll first.
Lakshman sir, is it necessary for her to tell how to differentiate clinically?
I don't think so.
Okay.
You mean in what?
We go the previous slide. She has mentioned the differentiate diagnosis. How she differentiates all this from CA? Is it necessary?
Yeah. Well, to some extent it's yes, but she started saying that it has been discussed so many times, we're not going to go into detail.
Okay, sorry.
So that's why I didn't insist on
Yes,
it.
sir.
Yes, it is possible to some extent to say this is likely to be neoplasm. Okay, both by clinical grounds and by investigation.
Yeah.
But do you want to discuss it again now? We can.
No, I'm asking you.
Yeah. At the moment, we'll skip it for now. Just
Okay.
go on with this. Yeah.
Yes, sir.
Yeah.
So first we'll be doing the ultrasound neck. Actually, in order, the first investigation is to confirm the diagnosis with ultrasound. Then we'll be doing ultrasound guided FNAC, and laboratory investigation comes the next. But for theoretical purpose, I'll go one by one. So ultrasonography, high frequency ultrasonography is used here. Highly sensitive for thyroid nodules, can depict the nodules varying from few millimeters in size. It can detect non-palpable thyroid nodules. So it will differentiate solid from cystic nodules, and it can detect adjacent lymphadenopathy. The features suggestive of malignancy on ultrasound includes whether the swelling is complex or solid, or irregular margins. Irregular margins are there, or if the margins are regular. Irregular margins suggest malignancy, and the swelling taller than the wider can be more towards malignancy. Microcalcifications and halo around the nodule, enlarged regional lymph nodes, and increased vascularity points towards malignancy. So these are the microcalcifications noted here. Fine needle aspiration cytology.
1 second. I really don't know. Why do you get microcalcification in ultrasound in malignancies?
Sir, sorry, sir.
Why do you get microcalcifications in malignancies? Even in breast also you get, no?
Yes, sir.
On ultrasound. Why? Sir, I don't know. That's why.
I'm not sure.
Any postgraduates? I can give you the answer, but any postgraduates to go for it? Why do you people get calcification? See, it's not only an ultrasound; it is detected on ultrasound. So why does one?
Microcalcification actually, yeah.
Correct. Why does one get calcification in malignancy?
Sir,
Why
sir,
does,
because of malignancy, there is rapid growth of these tissues, followed by central necrosis, which eventually leads to dystrophic calcification, sir.
Correct. That is the word for it. Okay, dystrophic calcification. That is a part of all malignancy. Yeah. It can also occur in ischemic tissues. It can also occur in chronic inflammatory tissues. Okay.
Okay, sir.
Yeah. Okay. Go on.
Yes, sir. So FNAC, ultrasound guided FNAC is recommended. It is the most important diagnostic tool. Ultrasound guided guidance increases the accuracy. So the sensitivity of FNAC is 83% and specificity 92%. False positive rate was 2.9% and false negative rate was 5.2%. So the limitation with FNAC is difficult to differentiate between follicular adenoma and Hürthle cell adenoma and carcinoma on cytology, as it depends upon capsular and angio invasion. So the options in such lesions will be frozen section biopsy, post hemithyroidectomy, and true cut biopsy. True cut biopsy is not usually recommended due to danger of hemorrhage and injury to trachea, recurrent laryngeal nerve, and vessels.
What is the indication for true cut biopsy?
Sir, anaplastic carcinoma.
No.
Lymphoma. Sir, suspected lymphoma of thyroid, sir.
Yes, sir. Yes, sir. Okay, sir.
And anaplastic also.
Yes, sir.
In case you don't get an answer in your FNAC, because some of them will have a lot of fibrous tissue, Skirrus reaction, and so it's difficult to detect the malignant cells in these terms. So you can do it, because remember, if you want these diagnoses on minimally invasive procedures, because you don't want any major surgical intervention. So both in anaplastic carcinoma and in lymphoma, you do not really want to do any surgery unless it's required. And in anaplastic carcinoma, as you will discover later, the only surgery is hysterectomy in case the patient has gone into tracheal compression. Okay, otherwise nothing else works for them. And so, in lymphoma, of course, you need to give chemotherapy. So, for these two reasons, you would like to get a definitive diagnosis with an FNA-B if you can't get it through FNA-C. Okay. All right.
Okay, sir. Yes, sir. So, see, laboratory investigations, we'll be going with serum TSH levels, serum calcitonin levels if we suspect medullary thyroid carcinoma. Serum calcitonin will be increased and it is highly suggestive of MTC. It is a more sensitive marker than CEA. The PCR assays can be done for germline mutations in red proto-oncogene. Serum thyroglobulin levels, it cannot differentiate between benign or malignant disease. The thyroglobulins are, it will quantify the amount of thyroid tissue left in our body. So it is used in patients to assess the post-operative status. So pre-operatively it is of less use, but still we'll have to estimate the level of serum thyroglobulin pre-operatively to compare the post-operative thyroglobulin levels for following up the patients. Patients undergoing non-operative management of thyroid nodule, we could measure the frequent serum thyroglobulin levels. And post-operatively, if serum thyroglobulin level is increased, it indicates recurrence of the disease.
Yeah. No, just to clarify what she has said, in simple terms, thyroglobulin levels indicate amount of differentiated thyroid tissue in the body. It doesn't tell you whether it is malignant or neoplasm or benign. So as long as you have thyroid in the body, you will have some thyroglobulin. But when you have done a total thyroidectomy, then it's good to have a baseline thyroglobulin level. You know, she mentioned pre-op. Yes, you can have it pre-op. You can also have it post-op after total thyroidectomy. And then serial measurements are much more important than a spot measurement. So serially, if you have an increasing thyroglobulin levels, it means that your differentiated cancer, which you had removed at the time of total thyroidectomy, has probably come back. And so you need to investigate further to see where and if it has come back. That is the significance of thyroglobulin. Go on.
Yes, sir. So, to rule out coexisting pheochromocytoma in medullary thyroid carcinoma, we'll be performing urinary VME, metanephrine, and catecholamines. Serum levels of CEA can be measured, but it is non-specific. It is a better indicator of prognosis than calcitonin. So, new patients with medullary thyroid carcinoma should be screened for red point mutations and pheochromocytoma as well.
Janani,
Sir?
go back. You said no urinary VMA, metanephrine. What is the use of measuring these in cases of in this case of medullary thyroid cancer?
Sir, pheochromocytoma, if to rule out whether pheochromocytoma is coexisting or not, sir.
Okay, so if a pheochromocyte,
whether it's a part of MAN2 syndrome.
Yes, sir. That's
a concise answer. When you see a medullary thyroid cancer, it can be a part of an MAN2 syndrome.
Yes, sir.
In 25% of cases, not necessarily only an isolated MTC, which is of course 75% of cases. So you are duty bound when you are suspecting MTC to look for MAN2 syndrome.
Yes,
and as a part of that, you work up for pheochromocytoma.
And in these cases, you have to address the pheochromocytoma before you touch the thyroid, sir.
Correct.
Yes,
correct. Yeah.
Yes, sir. So radioiodine studies comes the next. It is recommended in patients having solitary toxic nodule or toxic multinodular goiter, mediastinal nodules, or ectopic thyroid. It helps in determining functional status of the nodule. Based on the radioisotope studies, the nodule can be hot nodule, that is toxic nodule, warm, normally functioning, and cold, non-functioning nodule. Non-functioning cold nodules are more likely to be malignant, but not always. So this is a normal thyroid scan, and this is the nodular thyroid. Here we could see the cold nodule, and this is the hot nodule. So coming to scintigraphy,
Just go back one slide. Yeah. question to Pawan, who's been very quiet. All right. Is Indraja there or Pawan there?
Yes, sir.
Pawan,
Yes, sir.
you look at this picture on the right of the screen as a hot nodule.
Yes, sir.
Why is the rest of the thyroid cold?
Sir, heart nodule in which the cells are more actively dividing, sir. They take up more radioactive iodine, sir.
They're not dividing, they're avid.
Yes,
Okay?
sir.
They take up radioiodine, but why should the rest of it be blank? Why should it be cold? Why can't it be normal and this hot being, more dense than the rest of the gland?
Sir, because they are in suppressive state, sir. Rest of the gland.
Why is it suppressed? You're right, but why is it suppressed? Janani?
Sir, because sir, I was also about to say the same, sir. I couldn't get the
Why is it suppressed? Ajit? Saurabh?
Sir, because of hypersecretion from this node, there will be negative feedback mechanism which will suppress the TSH, which will eventually prevent the rest of the gland from working.
Correct.
Okay.
That is the correct answer. Please understand that a hot nodule is an autonomous nodule. That is a word to remember and understand. Okay. It is outside the control of the pituitary thyroid axis. That is the definition of a hot nodule. So it's overactive, irrespective of what the TSH level is. But the pituitary is responding to this the thyroxine level, the secretion from the hot nodule. So TSH is very low. So rest of the gland, which is non-autonomous, which is dependent on the pituitary, will be cold. Okay?
Yes, sir.
You must understand these things and not blindly follow this. Okay? Please understand the mechanism that is underlying. Go on.
Yes, sir.
So these things have already been discussed. We have told them these things. In the last class, we told all these things, and still they have.
Yes. They need reinforcement. There is. I'm digressing a little bit. There is. If you know about Bloom's taxonomy of learning, there are different levels at which you learn, and postgraduates must learn at what's called the HOTS level. It's called higher order thinking. That's why it's called higher order, HOT, hot learning. And essential difference between hot and lower levels of Bloom's taxonomy, which is recall, is exactly what it says. You must analyze things and understand. But our students are still at the recall level, makika maki. They're still, they're very good at, you ask them, for example, I would never remember a percentage of something.
Because it is your fault.
It's my fault, correct.
Yeah,
so,
spoon feeding, too much spoon feeding. Not allowing them to think.
No, I always ask them, I don't disallow them to think. But anyway, so you must analyze why things happen, and that makes it more interesting and more easy to remember. If you just mug up things, and it won't help you at all. Please keep analyzing everything that you read. It's important. I'm sorry about the digression, but carry on. Yeah.
Yes, sir. So, in cases of medullary thyroid carcinoma, the occultite scanning can also be done, which is 70% sensitive, and X-ray and CT scanning, which are we are not doing it regularly, but still chest X-ray and X-ray skull can be done to rule out metastatic deposits.
What is the basis of doing this occultite scanning?
Sir,
scientific basis.
Sir, there will be more uptake in medullary thyroid carcinoma, sir. Occultite scanning.
I don't know why there is no more uptake. Why not in other malignancies?
It is the biological nature of the cells.
Yes, sir. Yes, sir.
What is more important is that your iodine isotopes 131
yes,
or 123 or whatever, which is used in the normal CT scanning of thyroid.
Why medullary thyroid does not take up iodine scanning?
Because it is not from the thyroid cells. These are from the C cells.
C cells,
parafollicular cells. So
yes, sir.
That's so you must use the thing that the cell of origin takes up.
Yes, sir.
That is the reason. Yeah.
Yes, sir.
This is higher order thinking, Janani. Please keep thinking like this. You will understand.
Yes, sir.
Okay.
Yes, sir.
All right. Yeah.
So the CT scanning and MRI can be done to evaluate the extension of the suspicious or large thyroid masses into neck, trachea or esophagus, and look for metastasis to the cervical lymph nodes. This is the
and the chest.
sorry, sir.
All right.
Yes, sir. Okay.
You must
Yes,
also, it's very unusual for thyroid neoplasms to be, plunging goiters or, mediastinal lesions.
Yes,
But
sir.
when one of the classic indications of CT or MRI is to look for the
Yes.
extent of the disease. Okay.
Yes, sir.
Yeah.
Okay, sir.
Yeah.
So a couple of painless, progressively increasing swellings in occipitoparatal region in X-ray feature. Sir, can I go ahead, sir?
Yes.
Any role for
Yes, sir.
PET scan?
Sir, PET.
How do you find out the metastasis? You said bones are the second common site of this thing. How do you detect all those meds?
Sir, PET CT is not routinely recommended, sir.
When it is recommended?
Sir, if any palpable lymph node, no, sir. Actually, PET CT is not routinely recommended, sir.
No,
It is
the
not
question
routinely
is, when is it recommended?
Sir, if palpable cervical lymph nodes are there, or
Sir,
if patient is having,
sir, in lymphoma, sir, once we get a true cut biopsy for staging, we can go for a PET CT. Yes.
Good. That is the real answer. When you have a lymphoma today, if you detect a lymphoma,
all lymphatic organs.
Okay, that is the classic indication for PET CT.
For staging.
The only other rare lesion, rare situation is when you have extensive metastasis.
Yeah, infiltrate.
Okay. And then you anaplastic, extensive metastasis everywhere. Then just to document where it is and to decide on palliative therapy, you might want to use a PET CT. But I, for one,
when
would not.
past the follow-up thyroglobulin is elevated and we cannot find out the local regional recurrence, then it is also.
Then do a PET CT.
Okay, sir.
Find out where it is.
Okay, sir. Okay, sir.
But all these are rare indications.
Yeah. But this is theory, no?
But you must know.
Sir.
Yes.
Okay,
very
sir.
correct.
Okay, sir. Okay, sir. So staging of the disease with TNM staging. So sir, should I explain everything, sir?
Yeah, go on.
I think
at least the major factors. Yeah, the size is very important in thyroid. Yeah.
Yes, sir. So T0 is no evidence of primary tumor, and T1 is tumor less than or equal to 2 centimeter in diameter, which is limited to thyroid. T2, tumor more than 2 centimeter, but less than 4 centimeter, that is 2 to 4 centimeter, limited to thyroid. T3, more than 4 centimeter, limited to thyroid, or any tumor with minimal extrathyroidal invasion. That is, and the next is T4A, any size of tumor extending beyond the capsule, which is invading the other outside capsule, and T4B is tumor invading prevertebral fascia or encasing the carotid artery or mediastinal vessels or extrathyroidal anaplastic cancers.
No, I'm sorry. Janani, go back one slide, Janani.
Yes,
when that question was asked about extrathyroidal invasion, you fumbled, which means that you have copy pasted this definition. If only you had read these definitions.
Which one, sir?
What is you now defined T4A and T4B?
Yes, sir.
These are extrathyroidal invasiveness, isn't it?
Yes, sir.
So when we are talking about what is the extrathyroidal spread, you fumbled.
Sir, actually, while examining, I was not sure on which to fix it to check, because we are not checking.
The question asked was, where does it go when it goes extrathyroidally?
Yes, so on examination, sir asked. That's why I got confused, sir.
All right, go on.
Generally, just go back one slide, 2 slides, I think. One more. Yeah, no, this one. You didn't explain this.
Sir, this one. Yes, sir.
You didn't explain this slide, yeah.
Yes, sir. So in less than 45 years of age, the TNM stage 1 is any T, that is, as I explained there, and any N or M0, that is cancer in thyroid only. Stage 2 is any T, any N, M1 and distant metastasis. And above 45 years of age, we have the different staging. Like stage 1 is T1, N0 and M0. T2, N0, M0 is stage 2. 3 is T3, N0, M0. And 4A is T4A, N0 to 1A and M0. 4B is T4B, any N and M0. And 4C is any T, any N and M1. Metastasis.
How are you more enlightened now, Saurav?
Sir,
not possible
before,
to remember, man.
No, sir.
I keep telling all of you, there is no point in reading these things out. The moment
no, sir. The highlight of the slides which I wanted to point out is that the age
45 years is the cutoff.
Yes.
Yes,
Yeah,
I agree with
years.
you. That is the only thing you must know.
Yes,
Remember, in the previous discussions we had,
that's why I skipped it, sir. Yes, sir.
We had a discussion whether it is 40 or 45 or 50.
Yes, sir.
Now
Yes,
it is now, as of now, it is 45 years of age. That's all you need to know.
Yes, sir.
Rest of
Yes,
it,
sir.
none of us will remember. So every time you see a cancer thyroid, go back to the book and look this up. That is what you need to do. Thank you.
Yes, sir.
Go on.
Yes, sir.
Yeah.
So, prognostic indicators in papillary thyroid carcinoma, we classify patients into low risk and high risk groups. Low risk patients are younger than 45 years, sorry, sir, 45 years and well differentiated tumor with no
Please
mets.
understand, you don't have to be apologetic. The TNM says 45.
Yes, sir.
Age is scoring, it is still 40.
Okay, sir.
It is not 45. You understand?
Yes,
this
sir.
is the
Yes,
kind
sir.
of differences that do occur in science.
Yes,
You
sir.
need not be confused or apologetic about it. One
Yes,
fellow
sir.
says one thing, the other
sir.
fellow says something else. But as far as ages is concerned, which is older than the current TNM stage, it is still 40.
Yes, sir. So then last time in clinical discussion, sir also said like for males it is 40 and females 50 to 55.
That's right.
Should we? Yes, sir.
That is
Should we
also
take
true. That is also true.
Okay, sir.
And yeah, that is also true. And if you remember in your clinicals, you can say that. But then you can, I would accept if my student told me, sir, it is different for males and females. I think it is 45, but I'm not sure.
Okay, sir.
And you can always go back to the book and refer. So I don't.
Okay.
This is the lower order thinking. This is recall. Recall is always a lower level of knowledge than a higher level where you have to analyze. So the point is that somebody who is that cutoff age is around 40 and 50 years of age, maybe 45 is what one authority says, the TNM says. So if you need to know that the classification, because the aggressiveness is different, because the biological behavior of the tumor is different, they have taken this cutoff level. Okay,
yes,
that's what you have to understand. Yeah,
yes, sir. So high risk includes more than 40 years or poorly differentiated tumor, distant metastasis and large primary lesion that is more than 4 centimeters.
4 centimeters.
4 centimeters. Yes, sir. So these are the various other scorings.
What is AGES, sir?
Sir?
What is AGES?
Sir, age, grade and extrathyroidal invasion and size, sir.
Yes, for size, okay.
Yes,
size.
That is more than 4 centimeter or less than 4 centimeter.
What is AMES?
Sir, I mentioned it here, sir. AMES is age, sex, extent, metastasis, size and grade, sir.
M is metastasis.
Yes, sir. Metastasis.
Yeah.
Age. Yes, sir. Here it is, sir. Age.
G is grade. M is metastasis.
Yes, sir. And here in games is extent, sir. That is no thyroid, no local extension. That is intrathyroidal. That it comes in low risk group, and high risk capsular invasion and extrathyroidal invasion. And also one more scoring system, that is metastasis, age, invasion, completeness of resection and size. Yes, sir. So treatment part, the thyroid cyst. So in case of thyroid cyst, the ideal treatment, that is solitary thyroid nodule.
The lymph node status, prognostic factor?
Sir, which one, sir?
Does the lymph node metastasis does not come under a risk factor?
It comes under metastasis.
Yes, sir.
Go
yes,
back.
Sir, it comes.
Yeah. It comes under metastasis. Yes, why don't we stop here for today? We have another 10 minutes for 1 hour. We can have some discussion and final comments from the teachers. Okay, and I'll take the questions in the text box, and then treatment wise we'll consider in the next class. Okay, So Ajit has a
Treatment
question.
and follow-up is there, sir.
We'll do it in the next
Yes,
class.
sir.
What is the sensitivity
Yes,
of
sir.
ultrasound to detect lateral lymphadenopathy and central lymphadenopathy? Ajit, this is a super postgraduate question, but if you have the answer from some paper, I'm welcome to get educated by you.
Sir, I have it from paper also, as well as Sabiston also mentions it.
Yes.
90 to 95% for lateral lymph nodes, sir.
Yes.
Well, very less as 50 to 55% for central lymph nodes, sir.
All right. Very good. We are educated about that. So Ravi Shankar says, what is the role of frozen section in follicular carcinoma?
Sir, if there is clinical suspicion of malignancy, we could try with frozen.
See, don't. Only when there is malignancy, you're asking for frozen section. So don't start with your answer.
When you
answer must be straightforward. Okay.
When you have got clinical suspicion of malignancy, you go for FNSC.
Yeah. Okay.
Yes,
and what is the role of frozen section in follicular carcinoma? The answer is simple. You see, I mean, the question is simple. We have done an FNAC. It shows follicular neoplasm. We have told that we don't know whether it is follicular adenoma or follicular carcinoma. And you have two choices.
Yes, sir.
When you do your hemithyroidectomy, you can do a frozen section and then decide whether you want to go for the total thyroidectomy or not. There's three choices, in fact. That's number one. Choice two is that you do a resection, do a hemithyroidectomy, wait for the regular the histopathology, and go for a completion thyroidectomy 3-4 days later. Or go for a total thyroidectomy upfront, which is rather drastic because that would be an unnecessary operation for a follicular adenoma. So his question is simple.
Yes,
what is the role or the usefulness, sensitivity, specificity, and things like that of a frozen section?
Sir,
anybody else? If you don't know the answer? Ravi, you want to give the answer?
Yeah, I think, it is still a very difficult thing. You need an extremely skilled pathologist to, to interpret it. And because of the limitation of the procedure itself, because it uses a cryostat, and the specificity and because you need to look at the capsular and vascular invasion, which may not be very obvious on frozen section. So it is about 50 to 60%, I think. So you are still in a very difficult area, because if it is neither here nor there. So
I have a feeling the sensitivity is a little more. The false negative rates are in the region of 15 to 20%, if I remember my statistics right, my percentage is right, but still that is high. All right. Yeah. And so in fact, the other issue is that frozen section is very difficult to get. Not all hospitals give you that facility.
Yeah.
And that is driven more by medical legal reasons than by technical reasons. Technically, cryostat is an issue, but many people have it. But with the increasing medical legal situation, people are worried, pathologists are worried about getting the frozen section wrong and then getting sued for it. So many hospitals which were giving frozen section service earlier have stopped doing it now. And so we'll probably end up with a hemithyroidectomy and waiting for the regular histology to do a completion thyroidectomy later if required. And that possibility is about 10 to 15%, not more.
Okay.
Okay.
Okay, sir.
All right.
Yes, sir.
Sir,
8th edition takes a cutoff as 55 years. And that is for females, right, Saurav? It's not for all gender, not for all people.
So I'm not sure, sir, because in the AJCC 8th edition, they just mentioned age as 55. They didn't mention it as male or female.
All right.
So I'm confused a little bit, sir.
So
about that.
We'll go back to the books and confirm it, okay?
Okay,
but
sir.
The point to understand is that if you are older, more likely to be malignant. That's all. Yeah. Okay.
Sir, sir,
yeah.
In Sabiston I quote, sir.
Yeah.
They say that the frozen section is notoriously ineffective.
Right.
So what should we students should answer in exam? Should we quote
this is a $1 million question. That's why I always give a lot of importance to examiners who come, MS examiners who come and ask them what is your view, and they are themselves divided. Okay. And so what you have to do is, but I also insist that I don't think you'll fail on the basis of one answer. So it is reasonable to say that frozen section is not very reliable. You know,
Wait for the
Ravi talked about 40%. I talked about 20%. We are probably both right because different papers will give you that, and you talk about notoriously inaccurate. That is a strong statement. I don't think one should make that. But in the exam, to answer your question, you say frozen section is considered generally difficult to get as well as being inaccurate. And
don't
so,
commit yourself.
Yeah, and so it is not generally recommended. Just say that, and then if he asks you for percentages, you can say I have read the false negative. I have been taught or read the false negative rates to be 20 to 40%. And if you say that, I think examiners will be okay. You understand?
Okay, sir.
Yeah. See, please understand that even the examiners know that there are certain things which are controversial. And if somebody, I can tell you this also, if somebody is talking to you about the percentage of frozen section accuracy in a clinical examination, you're probably passed. He's trying to give
gone beyond that stage.
Trying to give you a distinction.
A distinction.
All right. So don't worry about that. Yeah. Okay. Next one. Next question. I think we're done with the questions in the chat box. Are there any other questions so far? No. Shivaram, for your comments, please.
Good presentation. Most of the oncosurgeons have stopped doing frozen section.
Yes.
As we discussed, I think it's not very useful in thyroid malignancies when there is a follicular and we have to decide on that. It's not very useful.
Yeah. Niranjan?
Niranjan very silent today. Ravi Shankar also.
Yeah. Niranjan, your comments, are you there? Srikanth, your comments?
Sir, Ravi Shankar sir is getting.
I've asked too many questions, sir.
You are Saka. Okay. Abdul?
Thank you,
Sir,
sir.
it was a good presentation, sir.
All right. Ravi?
Excellent presentation. That's all.
Good presentation. I was a bit late. I had to pay my respects to Swami Harshanandji who passed away today.
Yes,
so
yes.
I had to go there.
Hardcore Ramakrishna Mutt man. Good.
Yeah,
yes, I think it's appropriate. Yeah, very nice. Yeah. Okay, I think it was a good presentation, Janani. But
very good.
my only.
Your first year or second year?
Second year, sir.
Yeah. Okay. So my only.
You also got. You got. Oh, no, Indraja got married. Okay.
Yeah.
Janani
is already married. Yeah.
Married.
Janani, my only comment
very good
is,
presentation here. Very good.
Yeah. My only comment is that please try and understand all the things that you put on the slide.
Yes, sir.
Okay, don't mug up. Be firm on your answers.
That is the main thing. Don't mug up things. And when you're doing this presentation, it must not be a cut and paste job. You know, you take one table from one book or one website and put it on your slide. That's not. You must read about it, understand it. If you don't understand, you can always ask your mentor. We're always there to help you. Okay.
I have also done what you have done, but I have also fallen into problems.
All right. Okay. Thank you very much, everybody, for being here, and a good night. Next time we will continue with the second half of this presentation.
Sir, one more small presentation. Tomorrow is the ward rounds, so I would request all the senior surgeons to come so that their views will be very useful and very valuable.
Tomorrow is 13th, right? Yeah, I'll be there tomorrow. 14th we have a meeting, state committee meeting, but yeah, tomorrow I'm free. I'll come there.
Okay, so tomorrow there are a few good cases, so we'll do it like the
Zoom rounds, huh?
In the Zoom rounds.
Sure.
What timing in a
At the same 9 o'clock.
Okay. Sir, I'll send the notification now.
All right.
Okay. Also, Dr. Abdul.
Yes,
Abdul,
Dr. Shivram.
Yes, sir.
Can you put next month's post now only? Because